Welcome to the ManagedCareCGM.com presents Diabetes Quality Management, Trends and Opportunities for Continuous Glucose Monitoring in Managed Care Pharmacy. I'm Fred Goldstein, the president of Accountable Health, a population health consulting firm, and I'll be your moderator. It's my pleasure to ask our panel of experts to go ahead and introduce themselves.
I'm Dr. Timothy Gilbert. I'm a clinical endocrinologist out of Lake Charles, Louisiana, part of a large multi-specialty group, but did a good part of my career here in the New Orleans area training. So look forward to talking.
Hi, everyone. My name's Dr. Maureen Hennessey, and I'm Senior Vice President and Director of Value Transformation with Precision Value. We work with life science companies to help support their customers with transitioning into value-based care paradigms, many of which are associated with population health quality measures. I also am a certified professional in healthcare quality and work a fair amount with NCQA on various initiatives and serve on their industry healthcare quality council. Thank you.
Hi, I'm Susan Wescott, and I work at the Mayo Clinic in managing our health plan. We have about 170,000 lives with Mayo, and then we also serve other health system and hospital clients who are also self-insured.
My name is Sean Chitwood. I'm a pharmacist, a clinical pharmacist with Optum. Government program side, I work with external clients to ensure and improve Medicare stars quality, look at strategies, and truly work with them to strategize and figure out what they can do to improve. So it's a great opportunity to be here.
Welcome to all of you. We have an incredible panel, so very excited about this. The goal of today's discussion is to provide you with timely, relevant use of the best available evidence-based data on clinical and economic outcomes that can impact your entire healthcare system to improve outcomes for your members with diabetes. Our managed care and clinical specialist faculty will collaborate on the review of the clinical data, quality measures, and health plan best practices with a peer-to-peer idea exchange and a moderated discussion. Today's program is jointly provided by Medical Education Resources and Impact Education, LLC. This activity is supported by an independent educational grant from Dexcom Inc., Medical Affairs, and we would like to thank them for their support of this event. And now for just a quick few housekeeping notes. To receive continuing education credit for your participation, you must complete the program evaluation form. Your feedback is extremely valuable to the team, and we appreciate you taking the time to complete that form. And now let's get started with today's program, beginning with Dr. Gilbert.
My portions are typically very informal. I'm a clinical endocrinologist. I'm seeing patients nearly every day of the week. I treat adult and some pediatrics by default. I have two other physicians with me, two nurse practitioners, and two full-time registered dietitians who run a large-scale endocrine practice. I have been a heavy utilizer of continuous glucose monitoring way back into the days when we were doing the wires and the shower bag that they would wear for 72 hours. You had to put it in a Ziploc bag to keep it from getting wet. There was no Bluetooth. And, it's hard to believe that now we're in a day where we can automate insulin delivery via a CGM device and an integrated pump, and the patient never sticks their finger. We've just come, so full circle with the therapies that we have available. And I'm going to kind of jump through some of these, and there may be some rationale behind it, and some of it may be more opinion. But really, what we're going to talk about is the role of CGM in expanding treatment paradigm, including GLP-1 utilization. So here is 3 tracings. These are patients that wore a CGM for a period of time. As a normal individual, and obviously we're all going to have some variability of glucose throughout the day depending on what we've eaten, stress, etc. But you see in the non-diabetic or the healthy subject, the overwhelming majority of our glucose are in that 70 to typically about 150 range. But when we look at CGM data, or continuous glucose monitoring data, we typically are shooting for that 70 to 180 range. And remember, when we're collecting CGM data, these devices are pinging a blood sugar every 5 minutes. And so we're hitting a sugar every 5 minutes and creating a graph that gives us great information into what a patient has going on day to day, particularly with their glucose control. If you look at prediabetes, what you can see is a few spikes are hitting up over over 200, maybe close to 250, but overall their average is probably still, within an A1C it's less than 6.5%. And what you see, it's just much more glycemic variability. It begins to look like kind of or maybe to me it's like a earthquake tracing from California or something. Yeah, it's just a lot of shaking going on, and all that shaking leads to bad things. And no patient feels well when their glucose levels are jumping around. Even if they go up and come right back down to normal, a patient feels horribly when they see or are experiencing this much glycemic variability. When we started using CGM, we realized, how much of the picture we were missing. Because traditionally, before CGM, we did an A1C every 3 months. A patient came in, they were supposed to be sticking their fingers, but they wrote, 15 or 20 blood sugars on a tablet in the parking lot, all by the same ink and on a fresh piece of paper. And it wasn't real because they didn't have any blood stains on it. And they bring that into you. So our decision on how to treat that patient was really just throwing something at the wall and hoping it stuck. We really weren't sure, is this a fasting glucose issue? Is this a postprandial issue, et cetera? But what we began to realize is that postprandial glucose excursions were really a huge piece of the type 2 diabetes problem. And it was a big piece very early on in that evolution of type 2 diabetes. And what we've seen is prandial glucose excursions or glucose spikes post-meal liberate a lot of complications, or they're the driver for a lot of complications. So we can often predict risk for diabetes-related complications. We know postprandial glucose excursions or swings can be affected by timing of a meal, type of a meal, amount of what the food eaten is, etc. But all of this is picked up on CGM, and we'll kind of jump to what we see as we evolve into this cardiovascular risk, and I would argue we're seeing similar problems at the kidney level, et cetera. We are all, the old term diabetic myocardium, and we don't use that quite so frequently, but a lot of those same hormonal changes are occurring at the glomerular level, likely driving renal dysfunction as well. What happens is, as glucose levels rise and we see hyperglycemia and we see glycemic variability or these glucose excursions post-meal, we see a endothelial dysfunction, or the term used here is a decrease in endothelial function, but really it's a dysfunction of the endothelium, or the lining of the vessels. And what also we see is a loss of that vasodilator effect, and so that's contributing to hypertension. So you're having stiffening of the vessels, plus the vessels are in a pro-inflammatory state. We realize that the vessels are in a pro-inflammatory state when we're seeing spikes in glucose. That inflammatory state then leads to expression of adhesion molecules, expression of more inflammatory markers, and then ultimately formation of atherosclerotic plaques, and that's where we set ourselves up for complications such as heart attacks, strokes, some of the many things that we see that go along with type 2 diabetes. But as I said, it really unlocked a lot of insights contributing to type 2 diabetes, and you're looking at, let's say, a preventative care approach instead of a reactive approach. And I think for most of our career, what we've looked at or had the ability to do is just react to something. Your hemoglobin A1C is high, well, I'm going to do this. Now, when we're able to, and more importantly, the patient is able to engage in their care, see what their glucose levels are, minute to minute and hour to hour, be alerted if they are experiencing a high. If they eat Krispy Kreme donuts, I don't know if that's everywhere in the country or just a New Orleans thing, but eat Krispy Kremes and their blood sugar goes to 400, they're made aware of that, and kind of getting patients to buy in. This just simply shows some of the data that you can pull from a continuous glucose monitoring report. We see everything from what we call a GMI, which is an estimator of hemoglobin A1C, and most of the time those are very accurate. We see average glucose level in this patient was 211. The standard deviation was 70. There's some minimal risk for hypoglycemia, and a good part of the time I think the patient was probably in range. Not traditionally the exact report that I lean on most of the time, but it's a variation there. So it kind of fits the bill for what we're looking at. If we look at pretty much any of the diabetes or endocrine bodies that have the power to make recommendations, including the American Diabetes Association, what we see is that the centers of care really support utility and the value of using continuous glucose monitoring in diabetes management. And we feel like diabetes devices should be offered to people with diabetes, and that's a Class A recommendation. And also, use of CGM is beneficial and recommended for patients that are at high risk for hypoglycemia. And then it's used to assess status by A1C and or appropriate CGM metrics at least twice a year. So looking at patients, whether they own the device or whether we're using a professional version, placing it on them and collecting the data. I think those are really key things to focus on quickly here. Now, the average glucose level comes down significantly from baseline within the first 30 days of a patient starting CGM therapy. So within the first 30 days, we see a significant reduction in the overall average glucose levels. And looking at, again, time in range or TIR, we're typically saying glucose of 70 up to a glucose of 180. And with that, we see is that the time in range significantly improved there again for most patients when they wore real-time continuous glucose monitoring, and these are patients that were not treated with insulin. And so everything got better. Whether it was our GMI or the estimated A1C, whether it was cardiovascular risk, time in range, when you wore CGM, everything got better. And it's often sometimes a battle to get patients to start anything new in the office. And patients, even though it gets them away maybe from sticking their finger if they ever were, patients don't like to walk into a practice and think that, okay, now I'm going to wear this device for the rest of my life. So I'm always a little white lie kind of guy. I always tell the patients, give me 90 days. Wear this for 90 days and come back in 90 days. And if you don't like it, we can take it off and we can talk about doing something else. Because I know for the first week or so, they're probably not going to be a big fan of it. But I know at 90 days when that patient comes back, they're going to want to fight me if I tell them they can't have their CGM anymore. It engages the patient. It's life-changing for patients. And I had a patient the other day that was wearing a CGM, and he was not on insulin. He had an A1C in the 5s, had lost a significant amount of weight. And I said, look, Dave, you don't have to wear this all the time. You can just wear it periodically if you want. And he goes, Doc, I'll never take this off because this keeps me honest. And I guess we were just talking just a second ago, and if you think about the studies that show here and further on in the slide set, the reductions in A1C that we're able to achieve with a device that has basically no side effects, it just engages the patient. And we're doing that for a cost that is significantly lower than any of our branded medications on the market. So, we authored the LEADER trial. These were intensively treated patients, so they were on 3 or more injections a day. We saw an average A1C reduction of about 1.5 points in these patients. These patients had never worn a sensor before, but in 90 days, a marked reduction in GMI and A1C values. So we know that, as I said, CGM improves time and range, and it reduces hemoglobin A1C, even in people who are not intensively treated with insulin or non-insulin treated patients. So time in range increased by 16% after 3 months of CGM use, and our A1C went down about 1.13% for patients who had an A1C greater than 7.5 at initiation. And so CGM was really associated with a decrease in mortality, type 1 and type 2 individuals. What we saw was a 47% risk reduction for type 1 individuals and a 14% risk reduction for those with type 2. I think one of the things that resonates over and over and over again, no matter what study we look at, is the fact that hypoglycemic emergencies go down. Diabetes-related emergencies plummet. I've seen studies that show anywhere between 16 and 17% down to 40 to 50% reduction in diabetes-related emergencies for patients who wear continuous glucose monitoring devices. Think about it. If a patient goes to the ER and gets sent home from hypoglycemia, it's probably $3,000 or $4,000, and some of y'all may be much more aware than I am on the exact cost. But I do know that if a patient gets admitted for hypoglycemia, that cost goes up significantly. You just paid for one of these devices for the next 10 years if you would have prevented that hospitalization. CGM use increases each year after intracranial have been used in patients with type 2 diabetes is the percent of patients using CGM on any insulin. And we see that it was, in 2021, it was 20%. I would argue that by today's standards, if a patient is on any form of insulin therapy, they should be on CGM. It's almost irresponsible not to be. Because what we're doing when a patient is on insulin, just take basal insulin, for example. We're having patients titrate basal insulin based on fasting glucose values, but we're also watching for hidden prandial glucose excursions or nocturnal hypoglycemia. Quick story about how these devices change lives. There was a gentleman in Lake Charles, very affluent gentleman who supports the local collegiate tennis team, and he's retired, traveled a lot with the team, was on basal insulin alone, had gone out of town with the team, was driving back, had a hypoglycemic episode, was fortunate enough that two 18-wheelers realized what was going on, boxed him in, got him off on the shoulder. When the paramedics got to him, he had a glucose of 27. He, at that time, relinquished his driver's license, hired a sitter to stay with him at night because he was fearful of death. We got him on CGM therapy. The guy's back driving again. There's no sitter. He is a much more independent person. He's back to the old Harry there was before this nearly life-taking or this very life-threatening hypoglycemic episode that he experienced. But we're seeing across the board, whether it's patients with insulin, and I would argue 24 data, the CGM use with insulin is going to be a lot higher, but we're seeing an uptake in CGM use even in patients who aren't on insulin therapy. And there again, emerging evidence suggests that lowering A1C values from a combination of GLP-1 therapy and CGM work. And when we talk about GLP-1, we're talking about things like semaglutides. We're talking about the newer one, the GIP, GLP-1 combination, tirzepatide. But we know that these medications work. They work incredibly. I think we're in a space where we're treating type 2 diabetes, and for the first time, we're not just treating a number. We're treating complications, and we're treating patients for really what they're at risk for. Because one of the things that I often tell patients when I meet a patient for the first time is, look, your diabetes will not kill you. It will be the heart attack, the stroke, the renal failure, the hypoglycemic event, whatever. That's what's going to get you. So we control the variables. We control glucose. We control weight, control blood pressure. We're now able to continuously monitor glucose values in at-risk patients. And then taking it a step further with the GLP-1 medications, those now even have an indication for cardiovascular risk reduction. So now we're able to specifically choose meds that are synergistic in their effect or synergistic in their use with GLP-1 therapy along with CGM, and we see a kind of an enhanced benefit, so to speak. And so for patients that were on insulin, any form of insulin, we saw a very significant reduction in A1C in the A1C users as compared to the control group, which were the non-users. And if you look screen left, it was non-insulin treated patients, and we saw basically the same results, and that was a significant reduction in hemoglobin A1C with continuous glucose monitoring usage, and far above what we saw in the non-users. So there again, CGM works, and it engages the patient to make appropriate decisions. So to kind of wrap up, I think it's important to realize that CGM can enhance the safety and efficacy of GLP-1 utilization, but I really think we're at a time, as I mentioned, where GLP-1s are just game-changing for us as far as the treatment of type 2 diabetes goes. And then we have CGM, which is also a life changer for these patients, and those two together are able to kind of have really changed the landscape, I guess I should say, on the way we're managing patients with type 1 and type 2 diabetes. So we know that GLP-1s carry a label about hypoglycemia. And typically hypoglycemia, when we're using GLP-1 therapy, is going to be seen in patients who are on insulins or on sulfonylureas. And I cannot tell you, we do a lot of VA system patients. How many patients come in, they're on metformin, they're on glucotrol or Amaryl, and they're on a basal insulin. And within a few months, we're able to eliminate the sulfonylurea, and we're able to eliminate the basal insulin using GLP-1s, SGLT2 inhibitors, and for sure CGM, because we would not be able to wean the insulin as quickly and as safely as we do without the use of CGM. The patient walks out with a little handwritten instruction. When their sugars are below this, drop your insulin by this. And we have it all laid out. It works very, very well. There's really no official guidelines for starting GLP-1 in patients that are among insulin users. It's on label. We use it. It works great. But my goal is let's pull off the medications that are higher risk. Let's get rid of the insulin if we can. Let's get rid of the sulfonylurea if we can. Those are medications that put that patient at a higher risk for a catastrophic hypoglycemic event. The third, I'm not sure that I agree with. I think it's all in how you lay it out, but it says 50% of GLP-1 users discontinue therapy after 12 months, 70% after 24 months. You know, that may be true. I think it's becoming much more commonplace with use, and I think at least in our practice, we rely heavily on GLP-1s, GIP combinations, as well as the use of CGM in that part of the practice. And then, you know, CGM can assist in starting or stopping or adjusting GLP-1s, as I mentioned. That's how we're able to make grand changes. We talk about time in range. I've got a printout. This gentleman 6 months ago was in range 23% of the time in using insulin. I saw him yesterday. He's in range 99% of the time not on insulin. You know, and it's that doable, but the only way I can do that is with real-time CGM, because it allows the patient to engage, but it's also allowing us to engage as far as we're able to print out the data, or the patient calls with a problem and our educators are able to link in and look at their data real-time, look at a two-week retrospective analysis of their glucose levels, and make meaningful and impactful changes versus the whole hemoglobin A1C way where we just threw something at the wall and hope we made the right decision. And with that, I'm going to stop, and I'll turn it over to Fred.
Fantastic. Thanks, Dr. Gilbert. And any comments from the panel?
About how empowering it is, for example, for that patient that you just described, to be able to real time understand his condition in such a clear and vivid way and begin to be more engaged and more empowered to manage the condition and to manage it with you as well.
I had a quick question.
Sure.
Because you mentioned the metformin, that you take them off, and
Not necessarily metformin, but you
Yeah.
can use the sulfonylureas of the insulin.
Okay.
Yeah. No,
so that makes more sense, because
No.
a lot of us are in health plan
Sure,
cost
no.
containment, and
Yeah.
we
No.
like metformin.
Yeah, no, I love metformin. No, I like metformin. I love metformin. No, I'm
Okay.
not aiming
Okay.
at getting rid of metformin. Typically, it's the insulins, the basal insulins, and the high-dose sulfonylureas is what we're going
It
after.
makes sense, and the SGLT2s also have that cardioprotective
Exactly.
effect and
The renal
chronic
protective.
kidney disease. So, thank you.
Yeah, no, I think thanks for teeing it up for the rest of us. I think so. To be able to talk about your experience in the office with patients, that's what we're all relying on, right?
Sure.
Like our high-level data is all relying on the fact that you are taking care of the patients in the office. So,
Yeah, Dr. Gilbert, I think about this with the population health hat on, and I think about, one, the engagement obviously is incredible, starting to get individuals more into their care, but also this idea of moving upstream in terms of prevention and trying to head things off a little bit. So with CGM demonstrating the utility for early detection, how can patients most effectively be screened for that?
So we were just about that earlier. I don't think we're at a point, to my knowledge, where we can definitively make a diagnosis of diabetes based on a CGM, reading. We still have to have, lab values of greater than 126 fasting or hemoglobin A1C over 6.5%. But by putting a sensor on a patient and having that patient see, maybe it's the pre-diabetic, and that they see that when they take in simple sugars, that their glucose level spikes to over 200 or out of a normal range, to engage that patient to, try to be more proactive and make changes. And maybe it's starting metformin. I think we give out metformin like should have candy dispensers of it in the lobby, So starting those patients on insulin sensitizers early, trying to engage them in activity, et cetera.
Any other thoughts on that from the group?
It's all moving in the direction of greater prevention,
Moving
which is
upstream.
where we need to go. Yeah.
Absolutely. So as you think about that as well, we're seeing it offered to type 2 patients that are not being treated with insulin. And there's this population essentially that can benefit from that, and having that data come through. So what would be the recommendation to health plans and managed care possibly using it?
As I mentioned, and I had the opportunity many years ago when we began to look at A1C reductions and compare those A1C reductions to the cost of the branded medications we were writing and what those A1C reductions were. Like, okay, we could, put you on a sensor and not really do anything, just get you engaged, get you in front of a dietitian to help you, or an educator to help you understand what's going on, and a lot of times achieve an A1C reduction that was equal to or superior to what we were seeing with SGLT2s, GLP-1s, et cetera, but it's getting patient engagement, but we were able to drive that at a much lower cost because CGM is a third the cost at a minimum of what a lot of our branded drugs are. So maybe that's part of it. And the other part is the global piece of just the financial part of it. I had to look up this morning. I did a expert opinion for the Louisiana Senate this morning on some healthcare issues. Dialysis, $75,000 a year right now is the average cost of dialysis. If you look at heart failure, if we can improve glycemic control, minimize cardiovascular risk, keep that guy from having the stents and ultimately having the open heart surgery or the renal failure, we have not only done what's right by the patient, but we've also done what's right by the system, and that is, save cost.
Yeah, and I think we see some use in type 2s. We're still playing around with that. I think there's pros and cons to both, but agree with you that the numbers we're seeing today are quite significant. When we think about adding another drug, we used to always say like 1.5 reduction, and we're seeing numbers that are bigger than that with just changing the lifestyle, essentially, right? So this is also a group who are often, past middle age, wherever that happens to be at the moment. And some of their lifestyle choices may have contributed to their condition. So how do we learn as humans? How do we change our behavior? And I think a feedback loop is super helpful in doing that. And I'm wearing one right now, Fitbit, so that this was one of our first behavior changers. And now we have this blood sugar feedback loop, and I can connect that with what I just ate, which was bread pudding.
Absolutely.
Yeah. I love what was said. I think, so I have an Auntie Lynn who is Hawaiian, and she grew up knowing what she ate made her bigger or smaller, and she married a white guy from Idaho who played like community college basketball, and he didn't know what he ate made it like he would eat a pizza, right, and be like, that's fine, and then as they got into their 30s, late 30s, there was a significant change. And they had multiple discussions about, like, don't you know what eating a pizza will do to you? And he's like, it's just going to give me energy. Like, it was, that simple conversation, and we'll get it, it's a little bit of like a COH, social determinants of health, and health literacy. All of that is simplified when you see, like, what your day looks like. All of that helps when they go back in, when you don't see the blood stains on this little sheet they're writing down. All that helps when you see a realistic thing, because they bring those sheets in, no blood stains, and they say, well, you need a refill? Oh, of course I need a refill, right? I'm taking all my meds, I need a refill. It doesn't help them, doesn't help you. You don't know what to move, and if you keep adding on, and they're not taking it, all of those pieces come in right here, and it's value. That's the kind of value as a payer. You're thinking, we don't want polypharmacy. We want education from all of those things are assisted by having this very easy change over time of glucose level.
Yeah, and I just add to that, we always talk about in the industry, well, we need to raise the patient's health literacy. No, we need as an industry to bring our health literacy level down to the patient level.
Right.
And that's where you get something simple like that that's easy to understand that you can use.
Yeah.
Mm-hmm.
Pizza does this. Right?
Yeah.
Right? I mean, you can say that all you want, but when they see it,
Yeah.
right?
Yeah.
Like, that's the thing. Like,
That's the key. Well, thanks so much, Dr. Gilbert, and the rest of you for commenting on that. We're now going to turn it over to Maureen Hennessey, and she's going to talk about HEDIS, quality measures, and the role of CGM. It's all yours.
Thanks. So Tim just did such a great job of illustrating with some of the wonderful experiences that he was able to bring so richly to all of us about patients and how they experience CGM and benefit from it. I'm going to start by just showing some statistics about where we're at. So the latest, most available data, HEDIS data, on hemoglobin A1C from NCQA shows that we really have a long way to go still in terms of adequate management of hemoglobin A1C. When you look at those 2022 statistics or think about those, we see that individuals between, as a population, only about half of them, maybe a little higher, 60, 69%, are actually in a place where their hemoglobin A1C management is considered to be adequate for their health. And also very disturbing is when we look at the poor control or inadequate control of hemoglobin A1C among plans, commercial, Medicaid, Medicare, we see easily a quarter, even as many as 40% of individuals in a population are experiencing inadequate hemoglobin A1C control. So we still have a long ways to go, unfortunately. But yet, I'm hopeful, and I'm hopeful because we do have data now, as Tim was suggesting or indicating, that shows that when we use CGMs, populations begin to meet or improve as a population their performance on hemoglobin A1C targets. As Tim mentioned, healthcare utilization and costs are also favorably impacted by its use. And quality of life is also impacted. So, for example, many of you may be familiar with the term diabetes distress, and that is a measurable concept. There are a number of scales out there that measure diabetes distress. Plain speak, I call it the emotional wear and tear of day by day living with a chronic condition such as diabetes that, as Tim indicated, ultimately can result in tremendous life-threatening and indeed mortality, costing comorbidities like heart disease. So it's very stressful for individuals who are experiencing diabetes, living with diabetes. And what the research is showing is that CGM use can actually, because it's empowering the patient, it's giving them more information to manage the condition. The condition is less of a black box, so to speak, if you will. They're able to decrease some of the stress that they're experiencing. They also have more confidence in being able to avoid hypoglycemia and avoid being in an emergency room for hours and maybe having to even be hospitalized. And also, they're even seeing some improvement in sleep quality and in treatment satisfaction. So it's not surprising then. I really want to encourage you to think about it from a patient engagement and patient empowerment perspective, because it really helps us to modernize our understanding, if you will, of the metrics that are associated with this condition. And the other reason why we think about it is because hemoglobin A1C, from a quality measurement perspective, it's a good measure. It's important. It's got validity and reliability, so scientifically sound. It's usable. Many stakeholders understand it. And it's feasible to use as part of clinical care. But it does have some limitations, as we know. So it can be impacted by many factors. It can be impacted, for example, by age. It can be impacted by an individual's red blood cell lifespan. It can be impacted by various comorbidities as well. And there's many others that we've already talked about that can impact this measure. But even more importantly, from my perspective, is the one that Tim mentioned earlier. It doesn't identify hypoglycemia, nor does it identify that variability, those peaks and valleys that can occur in the area of glycemic management. So using hemoglobin A1C, it's a good measure, but it alone is not working. I mean, we have, like I said, large numbers of individuals within populations right now that are not at goal. So we're seeing the field change. Quality measures and standards, they're evolving to include CGM, and they're evolving to include CGM to achieve more optimal diabetes management. We started out really focusing in on using the A1C to help us manage diabetes care. We are now at a point where CGM is being used, and the GMI measure, if you will, is a bridge to more optimal measures in the quality management landscape. So ultimately, we're going to see, I think, time in range being integrated into various quality measures, time below range, hitting on that hypoglycemic issue, being integrated in, so that we can cross that bridge over into optimizing diabetes management. And of course, there are innovations in terms of therapies as well that are going to further help us with that. But there are some barriers right now to diabetes technology being used. For example, there are some plans that are still requiring a manual prior authorization. And when those barriers are not circumvented, then we see more challenges for individuals. And that is a very important issue to think about, because what the data is suggesting is that advancing CGM use can increase both the knowledge of the patient and the knowledge of the physician or healthcare provider in managing time and range issues. And that's important because we're seeing that time and range and optimizing managing time and range can impact conditions like retinopathy, neuropathies, CV mortality, to name a few. And NCQA now has recognized the importance of introducing technology into their measures and into practice. They are actually revamping their diabetes recognition program, which is a program that recognizes performance by clinicians who are high performers from a perspective of evidence-based practice in the management of diabetes. They're recognizing that increasingly technology is being integrated into the management of diabetes. And so we see for the first time this year that the A1C control for patients with diabetes measure has been revised. It has a new label, glycemic status assessment. So if you look at 2024 HEDIS measures, that's what you're going to see rather than the A1C measure. But even more importantly, what they did was they now incorporated into that measure A1C or GMI. And this is very important from a perspective, so you can report either to meet the standard, to meet the measure. But what's really important here, too, from my perspective, is that when we think about social determinants of health, there are patients who have difficulty either for mobility or transportation issues or getting time off, getting to the lab to get their hemoglobin A1C measured. They have difficulty getting to their endocrinologist or their primary care physician because of any of those issues that I just mentioned. Maybe they live in a rural area, for example, and it's harder to get access. Or maybe like during the pandemic, I can't tell you how many endocrinologists I said, gosh, it was so much easier for me to manage my patients during the height of the pandemic, because if they had the CGM, I could use that data to help me ballpark where that patient was at, and to help me if I made a change in their medication, to be able to gauge whether or not it was having an impact. So from a social determinants of health perspective, CGM, GMI is very, very empowering, particularly for certain populations or subpopulations. And to take it a step further, NCQA now has been very concerned about race, ethnicity, health disparities. They actually have 22 of their measures now that are stratified by race and ethnicity. And so what we see now is that in 2024, the eye exam measure for patients with diabetes is now stratified by race and ethnicity. Kidney health evaluation is now stratified for patients and for race and ethnicity, along with age. But also, for several years now, the hemoglobin A1C, now GMI measure, is continuing to be stratified for race and ethnicity. And we see that there's major foci on issues of health equity among, for example, CMS. We also see it among the Joint Commission. In fact, the Joint Commission has now elevated a standard that they had into a national patient safety goal around health equity. So where are we going if we look to the future? Well, hemoglobin A1C, GMI are two widely adopted metrics for gauging effectiveness of diabetes therapy. But the measures are going to continue to evolve. They're going to particularly continue to evolve as CGM use expands, as we get larger data sets and can answer some additional questions and set some additional targets. So one of the areas that I hear under discussion is, will we have a process measure that assesses the use of CGM? So for example, will we be able, in a community that we live in where maybe there's, 2, 10, 15 health plans, will we be able to see which of the health plans are most progressive in potentially providing access to CGMs among their individuals who are living with diabetes? Will we also potentially have that as a stratified measure? Will we be able to see, stratified by race and ethnicity, which individuals within a health plan, what percentage of individuals within a health plan are actually using CGM? Another area that we hear a lot of conversation about is, will time in range, time below range, time above range, will those become metrics that are integrated within diabetes quality measure sets? I hear a lot of talk about time in range becoming ultimately a metric. Questions about, will race ethnicity specific regression equations for GMI be developed, prompted by studies suggesting GMI and hemoglobin A1C may differ based on race and ethnicity. I've seen some studies that suggest that, for example, for Black African Americans. I've seen a few studies that suggest that for Chinese Asians. There's more questions to be asked about that for other races and ethnicities and to be answered. And so that's an area that's out there for further discussion and exploration, potentially. And yet, then there are other individuals who suggest that perhaps what we need to do is become even more expansive with our CGM data and metrics as we get more CGM use and more access to those metrics. Do we want to have a measure or in some way that actually uses very inclusive populations? We might have people of many different races and ethnicities. We might use different and have lots of different ages, so more variability that way. Type 1 diabetes, type 2 diabetes, various CGM devices, and look at all of that data and potentially develop mean glucose target ranges that can be used for additional data to help physicians and providers and patients better manage diabetes care. Perhaps at some point even replacing GMI, in which case you can anticipate that not only will the health plans, but entities that develop quality measures will further evolve their measures and the measure concepts as well. So it's a very dynamic field right now. The landscape is changing and changing rapidly. So I really encourage all of you to begin to think about how you can further evolve your organization's use of CGM to help improve those scores and those ratings that I showed you at the very beginning in the discussion. With that, I'm going to turn it over to you, Fred.
Any comments from the panelists?
You brought up a couple of great points, and one that I probably failed to mention earlier. When we look at the GMI, that is a rapidly moving number, unlike the hemoglobin A1C, which is a 3-month average. So we work very closely with a big group of orthopedists to do a lot of joint replacements, and we'll get referrals because they're not going to take somebody to the OR with a hemoglobin A1C of 9 or 9.5%. Traditionally, we would have had to have wait 3 months to get another A1C back. Now we can put them on a sensor. We track that GMI. When the GMI comes down, that may be within a couple of weeks, 2 to 4 weeks. We add a GLP-1 or we added a basal insulin. We were able to rapidly move that number. And to your other point, I think, GMI is really no different than A1C in the fact that it's a measure of the highs and the lows. We can have an A1C of 7 and everything be around 150, 160, or you can have an A1C of 7 with blood sugars in the 20s and blood sugars in the 400s. And those are two clearly different patients. And so I think time and range is really going to be where it's at in terms of assessing these patients long term, especially stratifying those that are at higher risk for complications.
Yeah, and I think these measures are really what move the needle between HEDIS and other measures. Because we've been talking about time and range, we need to use it more. Do we have that data on every patient? Not always. But that's how, as a nation, we move forward, is when we actually make that a goal that we all have to meet, and then everybody goes about meeting it. So I think that's really important in changing the landscape.
Yeah, the more the ecosystem adopts these measures, the greater the likelihood of superior outcome.
Yeah.
And the different lines of business, commercial and Medicare, and that'll mean something here at the end when we get more towards, when you have measures and HEDIS and like benchmarks, people are going to go to those benchmarks, and if the more they make, the more relevant they are to a health plan, finance-wise, that's a word. The more it makes sense, the more they'll pay attention to it. That's why the numbers are so much more drastically different in that Medicare population than everybody else, and other reasons as well. But I think when you're forced to look at it because of your dollars, you do it.
I think one of the things that you said that really stood out for me is that CGM gives you more data points to work with. Hemoglobin A1C is just not sufficient for many, many patients.
No, it's just an average. That's simply it.
And again, when I think about it from a population health perspective, for years we've measured process, and I would always say at the end of that, well, did they get any better? Sure, you did a bunch of this stuff, and you could show you called them 50 times, you did this or that, but did you make a difference in their outcomes? And now as we get more and more precise outcomes, we can really begin to measure what's going on and how we're doing as an industry to improve the care for people across a broad spectrum, whether it's in this area or another. So really fantastic. Really quickly, could we just touch a little bit on people's thoughts regarding this and health disparities and the possibility of using this to perhaps reduce some of those disparities?
Yeah, I think that what really becomes very clear to me is that when you have individuals who don't understand their care very well, who maybe can't get to an endocrinologist or even a primary care physician for a variety of reasons, which may involve mobility, may involve transportation, may involve that they live in a rural area. When you begin to look at all of those different factors, you see that CGM can help bridge those gaps potentially. And some of the data that you showed about across populations, you were seeing improvement in hemoglobin A1C and in general, really I think gives us a great deal to think about from a health disparities perspective.
Fantastic. I'm now going to turn it over to Susan Wescott on health plan best practices in CGM coverage and access, and then Sean Chitwood will provide some insights on quality components from the Medicare Stars perspective. So over to you, Susan.
Well, thank you. So we did have an expert panel that came together to look at what we all felt were best practices in this space. And certainly, it was probably about 2 or 3 years ago that I came to a talk, and there was a gentleman there from a Blue Cross Blue Shield plan who had just converted everybody to the pharmacy benefit. And if we think about our patients, when they go to get their prescriptions, pick up their insulin, it's really nice to be able to get the CGM, if they're using one, at the same time. So that convenience and access, and usually the hours are better. And many of our patients have a bad experience sometimes with the DME providers, and they're working long distance with those providers. So this has been really important to patients, and it came through loud and clear that pharmacy benefit was better.
There's also some financial reasons that the pharmacy benefit had some access to rebates, not so much of the government plans maybe, but for commercial, that's definitely been an eye-opener for me. Now that I'm looking back at the data since we moved over to pharmacy benefit, we're seeing pretty significant discount there when we add in our rebates, and it makes it a lot cheaper than I feared it would be to be able to help a lot of people. I think how we do utilization management, there's been some discussion today of sort of having almost none, but I'm still in the camp of I think we need to use these selectively, especially in the type 2 population. And so if you're going to use here, if you can automate that or use some technology to assist, I think that really is beneficial to everyone, to the providers and to the patients, so we're not all trying to, wait to get access. What we just talked about, looking at the underserved populations and other at-risk populations, and how do we use this technology to kind of address these niche problems that folks might be having, and where does it make sense and where does it not make sense? I still forget that some of our older patients don't have cell phones, and it seems crazy that they don't, but it can be overwhelming, some technology, so I think there's going to be really good fits and sometimes other places where it may not be working. And then education, we always have to have more education, learning from others and sharing that information with the patient and with some of the provider support can really be helpful. I love the CDE role. Those diabetic educators can really get into the individual needs of our patients and be able to talk to them about how to adapt their lifestyle specifically to address their goals. And then we need to continue to monitor our data to kind of see where we go with this as it unfolds. This is a study done in about 237 patients, and they've come back with 6 months of data and now showing a decline of about 2.3% from an average of 9.4 A1C down to 7 using CGM. And I was quite impressed with this because that is using the knowledge. So my original question with this whole type 2 group is, okay, so now they have all these readings. What are they going to use this information to change? What are they going to do? Because they are not going to all inject insulin. But hearing some of the results and the patient comments back from these studies is really interesting. They're going to change the next thing they eat. They're going to learn what foods to eat so they don't go so high. So there's a lot of lifestyle adaptation going on here, and this can replace the effect of another agent. When we look at the number or the proportion of patients who met the HEDIS target, which is 8 or below, it increased from about 20% to about 80% at 6 months. So that's pretty impressive. They then took this group of 237 patients and they interviewed about 34 of them. And this was aimed at understanding the why these patients were, what was their reaction? How was their behavior changing? And like I had just mentioned, they were changing their diet in response to a reading. Maybe not having that late night snack because they're already riding high. There's also this idea of maybe doing some physical activity. That can mean different things to different people. I don't know if it's always running a marathon, but it may be when I'm high, I might want to pick that time to be more physical, bring that down. And then medication adherence improved because there's a connection between seeing these numbers and then also knowing that my medication is working. Some of these silent diseases, we think about hypertension and hyperlipidemia, patients don't have a consequence from their disease for decades. And so it can get pretty easy to cheat and do all the things you're not supposed to do. But if you have this feedback loop, I think it really drives home the need to live a healthy life every day. And so some of the comments, I think we've heard this from other speakers, that being more interested and engaged in their type 2 diabetes management is an important thing. In this audience, even short bursts of use of a CGM can start to improve the patient's understanding of how their body's behaving. So even if they aren't somebody that is going to wear it all the time, there may be an advantage, and we have some disease management programs that do exactly this. They introduce a 2-week trial, then they go through 6 months, and they put another 2-week sensor on, and that is very instructive to the patient. And then a few more insights here. We know that all of our drugs, they all work. They work in some different ways, and they have different advantages, but they all do have side effects in some portion of our patient population. So if we can do something to maybe avoid having a multi-drug approach to therapy, this could be an area where we could focus. And I think as we look forward, we just have to identify who those patients are that we want to focus on. Because, honestly, CGM is not free, but it is a good investment in the right patient population. So really that's the key, is to identify where we want to start to use these CGMs. Another point that comes up is using it early in therapy. So if I've just been diagnosed with type 2, or if I'm changing therapies, that's a really good time to take a deep dive into that window and see the data, see what's happening every 5 minutes. And of course, you're adding a technology, so you're not adding another drug with other issues that come with that drug. So with that, I'm going to pass it over to my colleague, and we'll finish out this section.
Are you ready for this?
This is going to blow my mind.
You gonna knock it out?
Everybody, just take a breath, okay?
I don't think these chairs came with seatbelts.
Next time. So my position with my employer is in the STAR space, particularly the Part D, but I work over the last several months, have been doing some work with HEDIS measures and learning more about that. I have so many things to say as a pharmacist, as a son of a diabetic father, as my wife is a physician assistant, so as a husband of a prescriber, I have a unique perspective. And so many pieces of okay, here are the STAR measures, the quality measures that we have. And then, well, do they mean it? I know we started them because it was there to help people, or are they still doing that? And how can we change those? And that's one question. That's a completely different topic. So as a payer, what am I thinking? Well, in Medicare, quality measurement and STARS, this matters. And I think want to tell you when this even crossed my mind, my wife was working in the emergency department in Pennsylvania, and the ER doc, that was head of the ER, she'd been working with him for a while, and she came in, and one point in the middle of the night, she passed him walking over, and he grabbed his phone, and he wiped it on his arm, and he looked, and he said, and walked away. And my wife was very confused about, he nodded and then walked away, and did it 2 or 3 more times over that shift, and learned about this amazing, about CGM. And so she and I the Luke Skywalker hand, when I heard about that for amputees, a couple of CAR T therapy, as a pharmacist, as a clinician, a couple of things come by that are just truly amazing. And does everybody in the world qualify for them? No. When Lipitor was found, how amazing it was, I heard legitimate conversations about whether it should be put in the water, right, or the equivalent of that from doctors, because it was going to save everybody. And so throughout this, I'm thinking, okay, it does so much. I want one of these, right? I want my kids so they understand the science. I'm the science geek. I want them to understand and correlate food with their body rather than food with happiness, right? Because that's how my dad got to be where he is. All of that to say, as a payer, there's money in, say it bluntly, there's money in STARS. STAR, you can, as a health plan, if you have a contract, you're graded on a bunch of different things. On the Part C side, on the health plan side, you're graded on whether people are meeting whether they're getting tests, whether they're meeting certain things as was discussed. On the Part D side, are you adherent to your medications? Again, they want you to take your medications because they want the provider and the health plan, everybody to help them push taking their medications to improve diabetes, to improve high cholesterol and hypertension. And they put a lot of weight on those. And you can get up to a 5% bonus for that. So STARS are generated STAR measures and rating of health plans are there to improve the quality and to show health plans that CMS is serious about improving the health. And they even doubled down, talking about HEI and social determinants of health. They doubled down, and they've said, you know what, we're even going to bring that in. So you may be happy with the bonus payments you were getting in the past, but we're gonna make you go out and find specific populations and improve them too, or else you're gonna lose your money. Money talks, right? And so there's, real quick, for those of you who don't know, there's X amount of star measures. If there were 10, each measure, if they were equally weighted, would be worth 10%, or a rating of 1, right? 10%, 10 times is 100%. Well, some of these measures are 3 times weighted. Diabetes medication adherence is 3 times weighted. There's a lot of information about what it can do to improve, but I live on a high level, and in general, if you're doing more to improve their health, they're more adherent to their medications because the doc is going to be on top of them. They're going to keep the A1C at a good level. They're going to be aware of all those things. As you improve in star ratings, if a plan moves from 3.5 star to 4 star for their medical plan, that can be millions of dollars, depending on how big the plan is. So a small investment can be worth a lot. And so, again, the one thing I learned as a pharmacy student is the reason we care about Medicare is because of dollars, right? There's dollars there to help people stay healthy. And a big part of stars on both sides, the health plan side, the drug side, the medical, the drug side, are how does the patient feel? Like what member experience, how the patient experience, how do they feel about the plan? Have they left the plan? All of these pieces go to that. And if you can't get a hold on your member experience, that's higher weighted as well. And so this is very important. One of the things we look for is health plans will come and will say, how do we reach out? How do we improve this star? That's MTM or adherence or statin use in persons with diabetes from the drug side. And we know what they need. How do you improve adherence? They need to get the drug more. Like I can't walk in and get the drug from them, but they need to get it more. All of these things, they're looking for touch points. They're looking for opportunities to talk to their members, right? So the CGM offers an opportunity to improve, to get a higher fill adherence, and to interact with a pharmacist because of questions they have about their CGM, to have more accountability, as was said before. And so specifically, I know dual eligibles, people who are low income and qualify for Medicare, these are important populations and are only becoming more important when it comes to how Medicare is focusing on certain populations. And so the fact that people that we're seeing as the A1C drops, good things happen across the board on all star measures. People are more informed in general. That's impressive. Talking about broader use, I think one of the questions I would say, again, we don't want to put Lipitor in the water, right? But there's a benefit for my kid. I think if it was legitimate, and I'm not a bad father, I promise, 5 kids. But if I could help them realize the direct correlation between eating and their blood sugar, I think that would be great. I don't think we should put these on my kids. They're not diabetics. They're not, right? So at what point does a health plan, talked about earlier, what point does it make sense, right? Like at what point do you put the do you put the prior auth? And I think that's still for everyone to decide. Different health plans are different places there, but there is a benefit when it's introduced. We haven't introduced it to 2-year-olds, right? But I think there's a benefit at some point, and that's kind of the crux of where we're at now, and where to progress. We're seeing improvement across the board. If you have questions further on down the line, what is that going to do with retinopathy? What are the other stars the other star measures that are involved? Well, here it is. Here's reduced hospital use. You're not going to the hospital as often. There's an improvement in hypoglycemia and hyperglycemia. Why wouldn't there be, right? As you slowly start feeling bad, it's not great. I remember my sister called my brother-in-law because on his Apple Watch it said he had some blood pressure thing, and she called him up and said, go check it out. Right? Why? If you have someone watching you like my sister that can notify you of problems, hypoglycemia, you have that benefit of staying on course. And then, of course, retinopathy. Again, some of the star measures that are important to physicians and important to health plans because they're a star measure, because you're being measured on it. But also, down the line, you're thinking, okay, well, it's improving you're improving diabetes, you're pushing off heart attacks, and all these things matter. But what about, what can you tell us about, kidney function or retinopathy. It's all there. The data's there. And so the question is, how early do you as a health plan feel that your members, or Medicare, your members, at what point should they be getting that? Where's the value for you? Where does that feed into your approach to the coverage of these kind of products?
Fantastic. I want to thank you all today for your insight.